Congenital nasolacrimal duct obstruction is the most common cause of epiphora in infants and children with an incidence of 1.2 to 30%. Krigler's massage or lacrimal sac compressions form the first line of treatment below the age of 1 year. These compressions increase the intraluminal pressure within the sac and the nasolacrimal duct and break the membrane at the Hasner's valve, thus releasing the obstruction. It is important in this case to stress upon the correct technique for sac compressions and compliance for positive results. Using the index finger, pressure should be directly applied over the lacrimal sac area just on the inside of the anterior lacrimal crest, below the medial canthal tendon and without compressing the bone or the eye. Usual frequency advised is 10 times per session with 4 sessions per day. In case the symptoms persist after 1 year of age, probing is advised. Probing is a technique of passing a predetermined diameter rigid probe into the lacrimal system with an aim of overcoming the obstruction at the lower end of the nasolacrimal duct. Punctum dilatation is done. Syringing is done to confirm the nasolacrimal blockage. A smear of lubrication onto the probe in the form of ointment or jelly is applied. Probe of appropriate size is then passed through the puncta and the canaliculus with simultaneous outward stretching of the upper lid. Once a hard stop is felt, the probe is then withdrawn by 1 mm and then gently turned 90 degrees to lie flat on the forehead in line with the trochlea. Probe is stabilized using a finger on the superior orbital rim. It is then gently advanced into the lacrimal sac and the nasolacrimal duct in downward, backward, and lateral direction. No undue movements or force should be applied to avoid any false passage. Membranous obstruction at the lower end of the nasolacrimal duct can be overcome with a give way of resistance without application of much force. Probe should be pushed just for a few millimeters further so as to avoid injury to the floor of the nose and subsequently the palate. Presence of probe at the NLD opening can be confirmed by a metal-to-metal touch by placing a spatula in the inferior meatus at the nasolacrimal duct opening, or irrigation using fluorescein-stained saline, or direct view with an endoscope after medialization of the inferior turbinate. Endoscopic guidance gives a better control, allows direct visualization of the inferior meatus, and helps to avoid damage to the intrameatal portion of the nasolacrimal duct. Success rates of 78 to 93% is seen in children less than 36 months of age, and this rate decreases as the child grows older. In case of failed probing, repeat probing or balloon catheter dilatation can be attempted. Some prefer to use balloon catheter dilatation as a primary modality of treatment. When used as primary treatment, success rates achieved for the age of 12 to 24 months is about 82% and for the age of 24 to 48 months is about 75%. Balloon size used is 2 mm for children less than 30 months of age and 3 mm for more than 30 months of age. Probing is carried out as described earlier. After confirmation of the probe in the inferior meatus, the balloon is lubricated with viscoelastic and passed in the lacrimal system. Balloon catheter is passed till 15 mm mark reaches the punctum. 2 cycles of balloon inflation and deflation are performed. First cycle of 8 atmospheres of pressure for 90 seconds and second cycle of 8 atmospheres of pressure for 60 seconds. This is repeated after withdrawing the probe till the 10 mm mark. Patency is then confirmed with fluorescein stained saline. Silicone intubation is indicated for cases with previous failed probing and complex congenital nasolacrimal duct obstructions and can also be used as a primary treatment modality. When used as primary treatment, the success rate reported for the age less than 12 months is 95% and for 12 to 24 months is 92% and for 24 to 45 months is 84%. Results with monocanalicular intubation and bicanalicular intubation are comparable and can be used as per surgeon preference. Dacryoendoscopy is utilizing microendoscopic techniques to visualize the entire lacrimal system from the puncta to the inferior meatus. It helps in accurate assessment of the type of inflammation, locations of the fibrotic tissues, and recanalization of the nasolacrimal duct can be performed. Long-term results for this technique are awaited as of now. Treatment of last resort is dacrocystorhinostomy in persistent cases of congenital nasolacrimal duct obstruction which fail to resolve with the above techniques.